Okay, thank you, and thank you for having me. I've done quite a few of these in the times of COVID. I think this is my eighth one this month, I think, and it doesn't really get any less strange for me. Um, as you probably heard, especially if you logged on early, I have two small children and a husband, and it's bedtime, and there's not a lot of places to go to get quiet, and the 2-year-old doesn't understand what mommy's doing. So hopefully we won't have too many interruptions from them. So um, my name is Ashley. I'm a diplomate. I'm board certified oral pathologist. I'm a fellow in the American College of Dentists, and I'm associate professor here at UK. And I do promise I have no clue how I even got this on, this UK background. I promise I tried to change it to UT. I couldn't figure out how to do it. I don't have conflicts of interest. The opinions are mine, not UKCD's or Dr. Wynn's, and the opinions shouldn't be construed as advice to care for specific patients. Can you hear that? So upon completion of the course, we are going to be able to recognize common red lesions of the oral cavity, try to determine which lesions require biopsy and follow-up, and then how we're going to follow up. So mostly focusing just on red lesions. So this is the gremlin that you can hear. If you can hear him right now, he's running around in the hallway screaming. He's 2 years old. In this picture, he had just turned 1. So he's enormous and loud. This is Cash. He is 5. And I might have to pause here so I can tell my husband to get that stuff under control. Hold on. Okay, he took care of it. This is Damien, the child wrangler right now. So I do apologize for any distraction that might be happening right now. So Cash, during one of my presentations, I've learned to lock the door, but early on I did not, and he walked in, and I'm not supposed to say the F word, but he passed gas, and then loudly proclaimed he had done so. So that's actually quite entertaining. Maybe I wish that was happening right now instead of this one screaming. But anyway, I have children, and we're trying our best. And this is a reminder for me to turn off my webcam, because if Matthew McConaughey looks like that in a Zoom call, imagine what we all look like. All right, so outline of topics. So first we're going to talk about candidiasis, and then geographic tongue, and then I'm going to talk a little bit about hemangiomas and vascular malformations, and then we'll briefly talk about pyogenic granuloma and bumps on the gum. I know you guys are the experts at those. And then we'll talk about erythroplakia and squamous cell carcinoma. So I kind of wanted to go from routine entities that we see all the time, but yet I have found that dentists aren't really clear on the best way to treat them. And then all the way down to stuff that we just need to be able to recognize. So by far the most common oral fungal infection is candidiasis. And candidiasis presents in a variety of ways, and it can be sometimes difficult to diagnose, especially erythematous candidiasis. So we're all used to pseudomembranous candidiasis, the cottage cheese-like substance that you just wipe off, and it's very easy to diagnose, but the erythematous candidiasis is a little bit more difficult to see. It is mostly an opportunistic infection, but healthy patients may develop these lesions. And about half of us carry the organism in our mouth in health. So the reason I bring up that healthy patients can have it and it can be caused by many different things is because your patients might be confused. Like, how did I get a fungal infection in the mouth? I've had more than one patient say, but I'm not a female. How did this happen to me? And they're very confused that fungal infections aren't limited to certain parts of our body, and we can get them in the mouth and it's okay. So other than just randomly, things that can cause candidiasis, compromised immune system, altered oral and mucosal environment, like the patient took antibiotics. A patient might have a particularly virulent strain of Candida. Maybe they are asthmatic and they take a steroid inhaler and they forgot to rinse their mouth out. Maybe they have lichen planus being treated with steroids. So there's lots of different ways patients can get candidiasis. So I'm going to talk about erythematous candidiasis today, and that's what we're going to limit our talk to. Number one, we all know about pseudomembranous candidiasis, and number two, the chronic hyperplastic and mucocutaneous are more rare, so we probably won't see those. So I'm just going to focus on the erythematous. It's actually probably more common than the pseudomembranous candidiasis. It's just hard to see, and it's more difficult to diagnose. Under the umbrella of erythematous candidiasis, which just means red, right? So candidiasis that looks red in the mouth, there's many different ways that it can present. So these are 5 of the ways it can present: median rhomboid glossitis, chronic multifocal, angular cheilitis, denture stomatitis, and antibiotic sore mouth. So I'll go through all 5 of those presentations. I'll start with median rhomboid glossitis. It's also called central papillary atrophy. This is a disease of adults, and I bet next week, if you start looking, all of you will have a patient with this that's been undiagnosed. It is so common and often overlooked because it is asymptomatic and it is of chronic duration. So the patient might have had this for years. So clinically, it's a well-demarcated red zone, and it always occurs in the same place. It affects the midline posterior tongue, just anterior to the circumvallate papilla. It's asymptomatic, it's symmetrical. The surface is usually smooth, but it's allowed to be lobulated, and it's red because of a loss of filiform papilla. So here's the classic flat lesion of median rhomboid glossitis. Here's another lesion. So this is sort of a twofer, right? So this patient has a coated tongue. It is not quite, I guess you could call it a hairy tongue, but it's more of a coated tongue. And then you have this area of red right here. Sorry. So you have this area of red right here, and that's the median rhomboid glossitis. This is the fungal infection. Sorry, I muted you until my husband could take my screaming 2-year-old downstairs. Here's another example of median rhomboid glossitis. So you just have this central red area on the midline dorsal tongue. It occurs in the same place for every patient. And this patient I show last because next we're going to talk about chronic multifocal candidiasis. So here's his median rhomboid glossitis. And chronic multifocal candidiasis is a patient with median rhomboid glossitis and then another infection of another candidal infection. So the patient might have median rhomboid glossitis plus a lesion of the junction of the hard and soft palate, and that's called a kissing lesion. Maybe they have angular cheilitis. So this patient right here, so this is a fungal infection. This is median rhomboid glossitis. They also had this. So this might be scary to see if you don't know that erythematous candidiasis can present in this way. So if the patient has a red spot at the midline posterior dorsal tongue, that explains this redness. This is a kissing lesion. This is candidiasis. Here's another way it can look. This one sort of has some pseudomembranous component overlying it. You'd be able to wipe this away. But this is the hard palate lesion, the kissing lesion, so it's called, in chronic multifocal candidiasis. Angular cheilitis is an erythematous candidiasis that I sort of hold dear to my heart because I had angular cheilitis myself from the time I was probably in 7th grade until I was probably a junior in high school. And my dentist never pointed it out. My doctors didn't know what it was. And this is such a common infection. And once my dermatologist caught it, It was gone within 2 weeks. So I went for 5 years with these frankly gross lesions on the corners of my mouth that nobody knew how to treat. And especially being at that age, 7th grade through junior, that's not a fun time to have gross lesions on your mouth. So angular cheilitis is an important lesion to me because we can really improve the patient's self-esteem and aesthetics if we catch this and treat it properly. So angular cheilitis can be a component of chronic multifocal candidiasis, just like these lesions can. But it typically occurs alone. It is most common in patients who have a reduced vertical dimension of occlusion. And by that, I mean, it happens in older patients who are wearing dentures or who are supposed to be wearing dentures, but don't. So they don't have teeth and the corners of their mouth have slightly downturned. And then the saliva will pool at the corners of the mouth. So this is characterized by redness, of course, because this is an erythematous candidiasis, but these patients will also have fissuring and scaling at the corners of their mouth. And here's the other thing I want to talk about angular cheilitis that a lot of people forget. So about 20% of the cases are just caused by candida, and about 20% of the cases are just caused by bacteria. So we forget, because this is always taught in the fungal section. So we forget that occasionally these lesions are only bacterial driven. And most of the time it's both candida and bacteria. And by the way, I'm pointing this out because it is important to use the right medication, and I recommend clotrimazole for angular cheilitis lesions, and most people give nystatin, but occasionally nystatin doesn't work, and that's because it doesn't have antibacterial properties like clotrimazole does. So this is an infrequent occurrence, but angular cheilitis does spread to involve the perioral skin. It's usually because the patient is licking their lips or they're constantly using a petroleum-based solve, and I don't know why, but it's always Aquaphor. So basically what these people are doing is they're in pain in the corners of their lips, and it's cracked and it's dry, and they're trying to soothe it. So they put Aquaphor on it. But when they do that, all they're doing is sealing in the microorganism. And then if they spread it around their lips, they're spreading that microorganism. And that's called chelocandidiasis. So here is a very subtle angular cheilitis that I saw the other day. So this is a fungal infection or possibly a bacterial infection. But this is another one where if you look at your patients at the corners of their mouth, about once a week, you'll have someone with undiagnosed angular cheilitis. In this patient, I was actually called because she had pseudomembranous candidiasis that wasn't responsive to therapy. And I bring this up, and I'm going to go over therapy in a second. I made a little slide you can just print out and put on the wall, or hand to the doctor if you're a hygienist or whatever. But this patient was given nystatin, and I asked her, and they said, it's not, this fungal infection isn't going away. She must be immunocompromised. So I asked her, well, how often are you using the nystatin? She said, I use it every night before bed. And as hopefully we all know, that's not going to cut it. So we switched her to fluconazole, and I'll go more into patient compliance with antifungal medicines in a second. But she had angular cheilitis as well. So this is technically chronic multifocal candidiasis. This is your more typical angular cheilitis. So in an older patient who has reduced vertical dimension of occlusion, so scaling, redness of the corners of the lips. Here's another one. So you can see where it's cracked at the corners of the lips. This patient has additional pathology, which is why I like to use this photo. So this patient also has actinic cheilitis. So actinic cheilitis, even though it's not a red lesion, because it's in this picture of angular cheilitis, I'll tell you about it. So actinic cheilitis is sun damage. You might have heard of actinic keratosis. That's the sun damage that happens on the skin. It's a premalignant lesion. Once you can't see a nice border of the lower lip, so see here how you can tell exactly where the skin, the vermilion ends, and the skin begins, you can't draw that line on the lower lip. So that's the earliest sign of sun damage. And he's developing a bit of leukoplakia. So if we can get these folks, when they have this earliest change of actinic cheilitis, if we can get them to start wearing sunscreen, we can slow the progression to carcinoma. About 10% of these patients will get squamous cell carcinoma of the lower lip in a 2-year time period. So just something else to look out for, especially since you're in Texas and people are out in the sun. Here is a very severe case of angular cheilitis, and they've got some erythematous candidiasis going on in here. This patient's probably immunocompromised. And then this is a child who, look, you can see this is shiny, so they're putting something on the corners of their mouth, and then they're spreading this infection everywhere. So next is denture stomatitis, and that's also called chronic atrophic candidiasis. And it is characterized by redness, but it's localized to denture-bearing areas. I have crawled into my closet to get more quiet, so I'm sorry, I just hit the doorstop. So even with sort of a striking clinical appearance, like the patient will have bright red tissue, the patient will be asymptomatic. They're going to have no idea that their mouth looks like this. And patients with denture stomatitis, the typical story is they wear their denture continuously, maybe even 24 hours a day, and they take it out to clean it, but then they put it right back in. And the thing to remember with denture stomatitis is that the denture harbors most of the organism. So here I have a pretty classic example of where the removable partial denture was. I have a couple of really great with the denture in and then with the denture out. So this is a pretty striking redness that this patient has. Still, this patient would be totally asymptomatic. And then another picture. So denture in, denture out. So this striking erythema. And you can see even like where this doesn't really fit very well. That doesn't have any redness to it. And then this is 2 weeks after the patient was given antifungals and the denture was cleaned. So I went from this to this in just 2 weeks. The last pattern of erythematous candidiasis we'll talk about is called acute atrophic candidiasis. Most people call this antibiotic sore mouth, and it follows a course of broad spectrum antibiotics, and it feels like a hot liquid scalded the mouth. The dorsal tongue will diffusely appear bald, and basically these patients have the same symptoms and same look as xerostomia patients. So you have to have a good history that the patient just took antibiotics and now their tongue is burning. We can diagnose erythematous candidiasis clinically. We just have to be able to know what it looks like. Occasionally, it is helpful to perform exfoliative cytology. This is different from a brush biopsy. Exfoliative cytology, you just take the top layer of cells and turn them in, and we look for fungus. So I have probably done exfoliative cytology for yeast 3 times in the last 10 years. I usually just diagnose this stuff clinically. So here is sort of, I know this slide's busy, but I wanted it in like one slide. So you could take it and print it out and you had everything you would need. So for angular cheilitis, as I mentioned, clotrimazole is the best thing to use because it has both antifungal and antibacterial properties. You want to make sure that the patient isn't putting anything else on the corner of their mouth to seal in the organism. So the treatment for angular cheilitis is you tell them to go buy athlete's foot cream, and they put this cream on their mouth 4 times a day, once after each meal and then once before bed. And if they have to put Aquaphor on it, make sure they put the clotrimazole on it first. And try not to put Aquaphor on it or any other thing if they're not putting clotrimazole on before, because they're just sealing in the bacteria and making it worse. If the patient has chronic denture stomatitis, basically, so you can give the patient antifungals, and I often do, but that's not going to work unless the denture is also cleaned. This is my favorite thing to give rather than nystatin. I tend to give clotrimazole troches. The problem with clotrimazole is it is not absorbed systemically. That's also the great thing about clotrimazole. So the reason why it's a bad thing, so it's not absorbed systemically, so it relies on the medicine being in close contact with the fungus. So you have to take it several times per day. So for clotrimazole, you dissolve one of these troches on your mouth 5 times, or on your tongue 5 times per day for 14 days. And you have to finish all the medication, or the patient could risk getting a super infection. So that's 70 troches in 2 weeks that they have to take to clear their fungal infection. As I mentioned earlier with that patient I was telling you about with the nystatin, a lot of patients either don't understand this, they're not paying attention when you tell them how to take the medication. It's too hard for them to remember. There's a lot of patient compliance issues with clotrimazole. So if that's the case, I give fluconazole 100 milligram tabs, 15. You take 2 on the first day and 1 every day thereafter, and you have to finish all medication. The thing about fluconazole, the good thing is it's systemically absorbed. So you only have to take, with the exception on day 1, the next 13 days, you just take 1 pill a day. And most people can remember to do that. The problem is it's systemically absorbed, and a lot of people can't take this medicine. So if my patient has a long list of medications, I look it up myself, but I also just call the pharmacist because I don't have all of these memorized. I have erythromycin memorized, and that's about it. But I always call the pharmacist just to make sure, can I give fluconazole? So for most people, we don't give a lot of CE about candidiasis because it's very common. Most people know it, and it's really not that life-threatening. It's usually just an annoying superficial infection. And candidiasis should resolve easily if it's treated properly. But if it keeps recurring, we have to figure out why. Are they not rinsing their mouth out after the inhaler? Are they using topical steroids or systemic steroids? Are they immunosuppressed? And people don't really develop invasive disease unless they are in cancer therapy or in-stage AIDS or something like that. So are there any questions about candidiasis before I move on to the next topic? Okay, hearing none, we'll go to geographic tongue. So again, this is something that you guys, you all know what this is. So this is erythema migrans, or benign migratory glossitis. It's common. It affects 3% of the population. And I share that because I like to tell my patients that, they have never heard of this, and some of them are scared. So it's easy for me to say, oh, it's 3% of the population. I was in a dental school that had 600 people in it. I'm like, there's 50 people in here probably right now. I mean, I don't do math. 25. I don't know what. So 3 times 6, 20. What's 3 times 6? 3 times 6 is can someone help me? 28. Anyway, 18. I'm just seeing if you guys are paying attention. So there's 18 people in this building with it right now. So it's helpful for your patients to know that. So we don't know what causes this. However, people who are atopic, meaning they get a lot of allergies, or people who have psoriasis tend to get geographic tongue with higher frequency. And there is an association with fissured tongue. So classically, these lesions are on the anterior 2/3 of the tongue, and they might be concentrated on the tip and lateral borders. Geographic tongue is allowed to appear outside of the tongue, but they'll have well-defined border that helps with identification. That's a little bit beyond the scope of just regular geographic tongue. So these lesions apparently start as small white patches, but basically I see them start as red zones, and then they quickly enlarge and develop a border. They appear quickly, they heal within a few days or weeks, and then they come up, but in a different area. So they reappear in a different area. Patients are asymptomatic, typically. Occasionally, you might have a patient that says it burns when they eat spicy foods, but almost nobody has symptoms. Probably about 1% will have symptoms with this. And in that case, you use topical corticosteroids. There's no treatment for asymptomatic lesions. Just assure them this is not a malignancy. So I bring this up because if this very lesion was right here, this would be a fungal infection. But it's over here, and plus you can see a sort of sister lesion over here. This is geographic tongue. It's working on developing its border, but it hasn't quite gotten there. And something I want to point out that you won't see in like any book or anything is see these little like blebs. I always see that with geographic tongue. So here is a very tiny lesion of geographic tongue on the lateral border, but you can see these tiny little blebs. Blebs is not the technical term, but oh, this is a great example of, I see this quite often in geographic tongue and I rarely see it in other settings. But so you have this sort of red lesion, red lesions, and then they're partially surrounded by this white, slightly raised border. This patient is working on developing a lesion right here as well. And then the more typical lesions. So this tongue is red, and it's got all these white. I can see where someone might confuse this with pseudomembranous candidiasis. But if you look around, there's more lesions. So same for this border is quite distinct and thick, and it could be, if this was the only lesion, mistaken for leukoplakia. But if you look around, these patients will often have multiple areas that are compatible with geographic tongue. And one final example. So this is a pretty striking example. And again, these patients oftentimes have a fissured tongue. Does anyone have any questions about geographic tongue? Okay, we will move right along to hemangioma and vascular malformation. So a lot of people will say hemangioma / vascular malformation. The distinction is a hemangioma is a tumor and a vascular malformation is not. So a hemangioma has growth potential. Vascular malformations do not. The nice thing about hemangiomas is they involute on their own. So they spontaneously go away without treatment. Vascular malformations, unfortunately, will persist. So an example of a vascular malformation is a port wine stain. So I'm going to focus more on hemangiomas. And hemangiomas are quite common. They are, in fact, the most common tumors of infancy, and about 5% of 1-year-olds have hemangiomas. Females are more commonly affected, and Caucasians are more commonly affected than other groups. And these tend to occur in the head and neck. So that's why I like to mention them. They're common and they occur in our neck of the woods. So around 8 weeks old, a tumor with rapid growth appears. So usually the infant is not born with a hemangioma. Occasionally some are. And if the infant is born with the hemangioma, they tend to be a little bit more aggressive in nature. But around 2 months old, a tumor develops and it grows really rapidly. If it's a superficial tumor, it'll be bright red and raised and firm. Deeper tumors will look a little bit more blue. So this rapid growth phase, this proliferative phase will last for up to a year. And then after that, it can keep growing, but it grows proportionately with the child. After that phase, after it grows proportionally with the child, it will slowly involute. So the color will change and it'll start to feel less indurated, less hard. So the nice thing about these tumors is that they tend to go away on their own. So 50% regress by age 5, 90% regress by age 9. So when I get biopsies of tongue lesions that have a lot of vascular components, I will hardly ever call these hemangiomas if it's a patient who's older than 10, because these are tumors of infancy and they should go away by the time the child is 10. So about half of the time, the child will remain with normal appearing skin. You can't even tell they ever had a hemangioma, but sometimes the patient will have atrophy or scarring or wrinkling. Usually the treatment is watchful neglect, but you can use other things if there's problematic lesions or if there's some sort of intervention that's suggested. So I have a nice example of a hemangioma. This is a striking example. As you can tell, this one was present right away. So we know that this one's going to be a little bit more aggressive. So already you can tell this picture is taken a week apart, and you can tell how quickly it's growing. Like it's raised a little bit here and it's raised a little bit more here. So this image was taken just a few weeks later, and you can just see how quickly this hemangioma, the proliferative phase usually starts around 8 weeks old, but if you are born with the hemangioma, they tend to grow a little bit more quickly. And what happens is it starts growing so rapidly that its own blood supply cannot keep up. So it starts to necrose. So by Christmas of that year, this babe his tumor had necrosed because it was growing so quickly that its own blood supply couldn't keep up. So a bit later, you can see it's starting to heal around the edges, but you can tell based on this that there's probably going to be a significant scar. And here it's starting to heal up even more. And now so you can tell this is healing because this is the epithelial edge. It's closing by secondary intention. So you can see where it's starting to close in around this center area. See that? So the epithelium is starting to form a bridge around this. And here is, I think this is the last, okay, yeah, I have one more picture. So here is left with a little bit of scarring, but it's still hyperpigmented. And then this was the final result. I do have more pictures of him, but this is a pretty identifying mark. So I didn't want to, in the interest of his privacy, you know, his father is a dentist and let us use these photos. But now that he's a little bit older, I didn't want to give away any pictures that might have identify him, because he's a very handsome young man though. So here is a strawberry hemangioma. This is the classic hemangioma that 5% of newborns will get. And you know, several of my friends have children with hemangiomas. I feel strange asking them if I can take a picture for my lectures, so I don't, but I know several people who have these. And here's one that's a little bit deeper, so it can look more blue. And then these are examples of, are they hemangiomas? Are they vascular malformations? You know, vascular malformations can clot, and that might be what's happening here, but there should be no reason why they have this tumor-like outgrowth. So another example of what I would call a vascular malformation, but it could be just a hemangioma. And another example, and then another example of, this is why they're called hemangiomas / vascular malformation. Any questions about hemangiomas or vascular malformations? All right. I'm going to finish early, I think. I put a lot of time in here for questions, so if you ever have any, feel free.
I do got a question.
Oh, perfect.
For vascular malformations and hemangiomas, do you just watch it and just wait for digression?
So it depends. So most of the time, these hemangiomas are watchful neglect, like you're saying. So I don't have a lot of experience with treating these myself. So usually an ENT will, or maybe even plastics or derm. But in general, for most patients, we just watch them. As far as vascular malformations, so let me go back to, I mean, I would biopsy this because I don't know this is a vascular malformation. And I would biopsy, I mean, I would make a surgeon biopsy it. So Dr. Nguyen, I would make you biopsy something like this. I wouldn't feel comfortable doing it myself because I don't know about bleeding risks, but I would biopsy these if they don't know what they are.
The reason I ask, I have a case just like that, just like the tongue one on the dorsal tongue, not that one, like this one. Yeah, this one right here. And I did biopsy it. It bled like crazy. Okay.
Yeah, that's why I said I would let you do it.
And it's taking, it's not digressing as I would have expected, I guess.
How old's the patient?
She's in her 40s.
And it was diagnosed as a vascular malformation?
Yes.
Okay, I think that was appropriate treatment, but these suckers bleed, and I do my own biopsies, but I'm not particularly skilled with my hands. There's a reason why I'm a pathologist. So I like to refer to people who know a little bit more about surgery, like y'all.
Mm-hmm.
I got a private question that said, whatever happened to the young man? And he does have a scar on his face. So I'm not sure. I've lost touch over the past 5 or 6 years. But the most recent photos I've seen, he has quite a prominent scar on his face, but it's almost like a beauty mark. You know what I mean? Like it's a very unique, maybe he doesn't, maybe he hates it. I don't know. But I think it's kind of a cool little unique thing that he has. And I'm sure he could go to plastics if he wanted to, but I haven't seen a picture of him in about 5 years. So bumps on the gum. So we have pyogenic granuloma, which is the most common, and then we have peripheral giant cell granulomas and peripheral ossifying fibromas. So I saw 2 peripheral giant cell granulomas just today. All 3 of these lesions are reactive lesions. They're not considered true tumors. All of these lesions are likely a response to local irritation. So these patients will present with a smooth or lobulated mass. It's usually pedunculated, so that tricks people. So if it's on a stalk, occasionally a doctor will say, well, maybe it's a papilloma. But it bleeds easily and it's ulcerated typically. Patients are usually younger, so found in children and young adults. And the younger they are and the younger the lesions are, they look more red. But as the lesion is allowed to sit there for a while, it can become sclerotic and will look more pink. These typically occur on the gingiva, but pyogenic granulomas are allowed to occur wherever they want. So peripheral in oral pathology means on the gingiva. So peripheral giant cell granulomas and peripheral ossifying fibromas, by definition, can only occur on the gingiva. But pyogenic granulomas can occur on the upper lip or on the tongue or wherever they want to. This tumor also happens with some frequency in pregnant women, especially the first trimester. So much so that this is often called a pregnancy tumor. And I call that out because some regress after pregnancy. So while the treatment for most pyogenic granulomas is to excise them and send for histopathologic evaluation, if the patient's pregnant, you can defer treatment. So like I said, treatment is surgical excision, and you have to go down to the periosteum and you have to scale the adjacent teeth. So on my sign outs, I'll say lesional tissue extends to the base of the specimen. And what that means is this has a chance of coming back. So about 15% recur. No matter how good of a surgeon you are, they come back. So it's good to tell your patients like, hey, I'm going to take this off, but there's a good possibility it's going to come back. And then for lesions that's developed during pregnancy, you can defer treatment unless functional or aesthetic problems develop. And there's 2 reasons for that. Number 1, we talked about it might spontaneously resolve. But number 2, the recurrence rate is higher for pyogenic granulomas that are taken out during pregnancy. So here's just a classic pyogenic granuloma. You can see not great oral care there. So it's ulcerated. This is going to bleed quite easily. And this is a pyogenic granuloma as well. So this will be the only thing, that we talk about in this section that can occur outside of the gingiva. So this is a pyogenic granuloma. And then more pyogenic granulomas. This one almost looks like a localized juvenile spongiotic gingival hyperplasia to me. And if you don't know what that entity is, you are not alone. It was recently discovered, and I don't know that most schools have incorporated it into their curriculum yet, but localized juvenile spongiotic gingival hyperplasia is something that happens in children, and it looks exactly like this, like somewhat velvety and papillary. This is too bulbous to be considered a same lesion, but this sort of looks like LGSGH. And this is another example. So bright red, bleeding. Oh, so someone's saying, I see localized juvenile spongiotic gingival hyperplasia a lot. I do too. It's not an uncommon lesion. So much so that if last week an oral surgery resident ran into my room and said, I have this kid, she's got these red lesions. And I just said, it's LGSGH. And the surgeon had never heard of it before. And I just, oh yeah, okay. So she works in pediatrics. So localized juvenile spongiotic gingival hyperplasia is treated by conservative surgical excision. So that's what I'm supposed to say. But what I will say is there's been some literature that application of a strong topical steroid can treat these lesions. So, and I'm talking like clobetasol, which most dentists are hesitant to give to adults. So you just have to have a talk with the family and see how they want to proceed. These aren't seen in adults really, so there's a chance they could regress. So sometimes we just leave them. But the official treatment is conservative surgical excision. But you can see where that might be a problem if you're trying to preserve aesthetics, which, by the way, Dr. Nguyen, I'll give you a shout out here. I always, when I was in Texas, would refer these to perio, because perio does a great job of, when they are taking out these lesions, preserving the aesthetics. And here's a lesion. They're usually on the buccal gingiva, but they're allowed to occur in the lingual. And then this is one where this was a pregnant patient, but this is obviously starting to interfere with function and aesthetics. Plus, I don't know for sure that's a pyogenic granuloma. It's enormous, but thankfully it was. Peripheral giant cell granuloma. So this is also a reactive lesion. It's a response to local irritation. This is likely a soft tissue counterpart to the central giant cell granuloma. And the only reason I mention that is because I'm getting ready to talk about peripheral ossifying fibroma, and it is not the soft tissue counterpart to the central ossifying fibroma. Because the central ossifying fibroma is a true tumor with significant growth potential, but peripheral giant cell granulomas, central giant cell granulomas, the peripheral giant cell granuloma just isn't considered a neoplastic lesion. Again, exclusively on the gingiva. These can look red or blue or purple, and the giant cells in this lesion might act as osteoclasts. So occasionally we will see a sort of cupping resorption of the alveolar bone when we take an X-ray. Treatment is the same as PG. Recurrence is the same as PG. So this one's a bit more purple. So this was peripheral giant cell granuloma. So this one might have been there for a while. You know, some pathologists don't think of these three things as distinct entities. We think of them more as a spectrum, like maybe it started out as a pyogenic granuloma, and then the longer it sits there, maybe it'll turn into a peripheral giant cell or peripheral ossifying. So here's that cupping resorption of the bone I was telling you about that you might see with peripheral giant cell granuloma. So the last bump on the gum is a puff that we'll talk about. And these are also reactive. They're not true tumors. So it is not the soft tissue counterpart to the central ossifying fibroma. These occur exclusively on the gingiva, typically in the incisor cuspid region. They look like bumps on the gum. The average age is 15, and they occur in females, and same treatment as any bump on the gum, same recurrence rate. So these are all reactive lesions, probably on the same spectrum. So we don't know what this is until we take a biopsy. And these just turned out to be peripheral ossifying fibromas. Here's a quite large one. And obviously this patient has poor oral hygiene. Any questions about the more common things that you all see? So those red lesions that are geographic tongue, candidiasis, bumps on the gum. Okay, so we'll move into hopefully what will be more uncommon lesions, but still we need to recognize them. So we'll start with erythroplakia, which is defined as a red patch that can't be diagnosed as anything else. So we talked about leukoplakia last time I was there, which was probably over a year ago. And it's a white patch that can't be diagnosed as any other condition. But leukoplakia is much more common than erythroplakia. We don't know what causes erythroplakia, but it's probably tobacco and alcohol and maybe even high risk HPV, but probably tobacco and alcohol. So like I said, good news, erythroplakia is a potentially malignant disorder that is not as common as leukoplakia. But the bad news is true erythroplakias are not benign. They're never completely benign. And almost all of them show severe dysplasia or worse on biopsy. So even though these lesions are uncommon, it is imperative that we recognize them clinically. And I just wanted to point out, so things can be red. That doesn't make them erythroplakia. So this is actually a picture of me after I clumsily took a bite out of my own lip. But you can see this picture is clearly caused by trauma, or excuse me, this ulcer is clearly caused by trauma. So this isn't considered erythroplakia. This doesn't have malignant potential. Another thing on etiology, so smoking cigarettes and drinking alcohol are well-known risk factors for developing oral potentially malignant conditions like leukoplakia and erythroplakia. Chewing tobacco isn't really considered that much of a carcinogen. It is technically a carcinogen, but the relative risk of someone developing an oral cancer because they use chewing tobacco is incredibly low. But there have been some studies that people who use chewing tobacco have a relative risk of 20 for getting erythroplakia. And all of this is to say, obviously smoking is still a very strong risk factor, but in some geographic locations, chewing tobacco might be more risky behavior than we think, because we usually think of chewing tobacco as probably don't do it, but if you're going to get a cancer there, it's going to take years and years. People who have high vegetable and fruit diets had less erythroplakia as well. So for erythroplakia, the differential diagnosis includes erythematous candidiasis, like we talked about earlier, but also atrophic lichen planus that is not surrounded by that nice white border. So those are a couple of things that might be confused with true leukoplakia, but a biopsy can sort it out. So the patient population is older. So the average age is 70, and unlike leukoplakia, which tends to occur in men, erythroplakia doesn't really have a gender predilection. So common locations include floor of the mouth, soft palate, and ventral tongue. Some studies suggest that the tongue is an uncommon lesion, but I still think we should include it. Also, some studies suggest the most common place is in females for erythroplakia to occur is the gingiva. And I have lots of examples of this. Also, when erythroplakia occurs on the gingiva in females, it looks like other pathology. So, and also these women typically don't have risk factors. They don't smoke, they don't drink. So these are especially troublesome. With erythroplakia, the altered mucosa is well demarcated. It's less than 1.5 centimeters in greatest diameter and has a velvety texture. It could have a granular surface, but by that point, it's probably a squamous cell carcinoma. The lesion is soft when it's dysplastic, and as it evolves into squamous cell carcinoma, which a lot of them do, up to, I forget what the studies say exactly, but they say about 85% in general, if you look at reviews. So these are very bad actors. The lesions are red because the epithelium is so thin and it's not producing keratin, so it's not doing what it's supposed to be doing, and then that lets the underlying vasculature show. Patients are asymptomatic, and a lot of the times they'll say, yeah, I noticed this a couple years ago. Erythroplakia must be biopsied, and the treatment is guided by definitive diagnosis. So 90% of the time, what you're going to do is an incisional biopsy, get your diagnosis, and then treat it by obliterating the tissue, because most of these are squamous cell carcinomas. If for whatever reason you're lucky enough to get back a mild dysplasia, you should destroy the tissue. Recurrence and multifocal oral involvement is common. So patients who've been diagnosed with erythroplakia must be followed up long-term. So every 6 months is required. I typically recall the patient every 3 months for at least the first year, and usually the first 2. But the literature suggests that these patients should be followed for 20 years at that regimen, at every 6 months for 20 years. So just a quick slide on leukoplakia versus erythroplakia. Leukoplakia is much more common. It can evolve, it can start out as a thin leukoplakia and become more dysplastic, can show areas of redness, so erythroleukoplakia. And while almost all erythroplakias are severe dysplasia or cancer on biopsy, only 20% of leukoplakias are. Both require biopsy. So leukoplakias, you have to biopsy them, even though a lot of the times, 80% of the time, they're benign hyperkeratosis. 20% of leukoplakias are mild or moderate or severe dysplasia or cancer. So this sentence is even a little misleading. I'm just seeing that now. So consider erythroplakia, carcinoma in situ, or squamous cell carcinoma until proven otherwise. But for both, long-term, close clinical follow-up. So this is one of my old students, Dr. Merrick, if any of you know him. He took an excellent clinical photograph for me. So this is a lesion he caught in a patient of his, and we weren't sure what to do about it. It looks like it has this hyperkeratotic border that's closing in, but it's erythroplakic, and it had been there for more than 2 weeks. So I said, take a biopsy. So he did, and it was mild dysplasia. So Dr. Merrick, because he was performing such great cancer screenings, now we can destroy this tissue and the patient will have a good outcome, hopefully. But if you look at this lesion, you can appreciate how easy it might be to overlook. So this white part really sticks out to me, but that's not the worst part of the lesion. This is the worst part of the lesion. So the ADA says their recommendation is to screen every patient every time for oral cancer. You at minimum want to look at the lateral tongue, ventral tongue, and try to check out their gingiva, which I'm sure you all have no problem doing. So here's more erythroplakia. So it's kind of sharply demarcated up here. I had this with severe dysplasia. I went back and more of it was carcinoma in situ. And all the rest of mine are cancers. But look at this lesion. This doesn't necessarily look like squamous cell carcinoma, right? It looks just like a weird red lesion. That's what these gingival lesions do. So erythroplakia on the gingiva, especially in females, they'll have no risk factors and they're scary. So this is squamous cell carcinoma. This is squamous cell carcinoma as well. This is actually a dentist who developed this sharply demarcated red lesion. She and her husband both thought it was vascular. Her husband was a dentist as well. So her husband just lasered it off. It came back 3 months later. So he lasered it off again. So this went on until about a year later, they decided to do an incisional biopsy to see what it was. And this was a squamous cell carcinoma. But they were shocked because this is not a typical location for squamous cell carcinoma. This patient had absolutely no risk factors whatsoever. And it was kind of a small lesion. So I have a question on thoughts on the oral ID, and I will talk about that in 1 second because the answer is really long and diplomatic. So I will talk about oral ID. So here's another erythroplakia, which was a squamous cell carcinoma. And I don't have great photos, but I wanted to show you, like, this isn't a great photo, but I wanted to show you everything that I had because these are kind of rare lesions, right? Only about 0.1% of the population will have them. But anytime you see a sharply demarcated red lesion like this, where you can see exactly where the red ends and the normal skin begins, that is bad. And then, of course, this one's squamous cell carcinoma. This would be quite indurated on palpation. So if you felt it, it would feel like a rock. And this might be an HPV-driven squamous cell carcinoma. This is certainly an HPV-driven squamous cell carcinoma. Which brings me to squamous cell carcinoma. So before we go into squamous cell carcinoma, I want to address the oral ID question. So the way that oral ID is, and I don't want to speak for the company, but the way that it's supposed to be used is as a diagnostic adjunct, not a screening device. So what I mean by that is you see this lesion, then you shine the light on it, and if it loses fluorescence, then you biopsy. If it doesn't, then you don't. So that is the intended use of oral ID. Nobody uses oral ID like that. We all use oral ID as a way to catch lesions like this that we might miss. So we didn't see this until we used oral ID, and then we saw it, right? So with that in mind, the ADA Center for Evidence-Based Dentistry did a meta-analysis and systemic review of every single article that had ever been published on oral ID. And they got a panel of experts together, including the immediate past president of our academy, Dr. Lingen, Dr. Kelmar, a prominent head and neck surgeon, Dr. Apt, who's a dentist and anyway, so a lot of important people, right? And that group published in the October 2017 article or issue of JADA that they do not recommend use of these screening devices. So that is the official ADA recommendation from the Center for Evidence-Based Dentistry. But all the studies are studying it as a diagnostic aid. They're not studying it as a screening device. So my opinion on the oral ID is, I think there is absolutely no harm in using it as a screening device. So long as, number one, you're not overcharging the patient. So some feel very strongly this should be included in the because you're supposed to do an oral cancer screening as part of your comprehensive exam. So some feel very strongly you should not charge for this. I don't have strong opinions because I also think there's going to be a cost to your office for extra things that you use. And also you had to take time and you had to acquire training to learn how to use them. So I have no problem with charging $20 for this exam. Number two, you have to know what you're doing. So I got a lot of referrals when I was in Houston of geographic tongue that lost fluorescence on oral ID. And the thing with oral ID is all inflammatory things lose fluorescence. So like implantus will lose fluorescence, ulcers will lose fluorescence, and geographic tongue loses fluorescence. You can't use oral ID on melanotic macules or things like that. So there's an appropriate, you have to know what you're doing basically. But I think only good can come if you are actually looking. It's a way of ensuring that people are actually going to catch this. So was that sufficiently diplomatic enough that the ADA doesn't recommend it as a diagnostic aid, because it has such low specificity. It has pretty good sensitivity, but like I said, because it picks up all these inflammatory things, the specificity is garbage for these tools. So a lot of people would get biopsies that didn't need them if you used it as a diagnostic aid. So in conclusion, use it as a screening device. Go for it. Does that answer your question? And by the way, Bellscope and Oral ID are the same technology. They're just, Bellscope came out first. Oral ID is run by Forward Science in Houston, and I've met with them. They don't pay me or anything, so it's not anything to disclose. But I've met with them. I've toured their facilities, and I can get the sense that the people that run the company really care about catching oral cancer early. So that is something I can say. All right, so now we'll talk a little bit about squamous cell carcinoma. So when we say oral cancer, it's almost synonymous with squamous cell carcinoma. So it's actually about 85% of oral cancer malignancies are squamous cell carcinoma. But overall, it's not a common cancer. So really only dentists, dental hygienists, dental assistants, only people in the dental world are really adept at squamous cell carcinoma. Even ear, nose, and throat doctors don't see it as much as we do. Men are more likely to get oral cancer when compared to women. And heredity doesn't play a major role. So I like to point that out because I'll have some patients come in every year for an oral cancer screening because their father died of oral cancer or something like that. To which I say, great, everyone should get a cancer screening once a year, an oral cancer screening, because all I do is look. I'm not putting any radiation. I don't have to take x-rays and to look for oral cancer on your tongue. But I will also tell you that hereditary factors don't really play a major role in oral cancer development, unlike others like breast cancer, where hereditary does play a major role. Almost everyone with oral cancer is someone who smokes. About a third of people with oral cancer drink heavily, compared to 10% of the population. And patients who are immunosuppressed are also at an increased risk for oral cancer. I don't know if I put this in here. I didn't. Something I want to bring up is that there was a study published recently, and it was all patients in California, but we can probably assume that, it's a good American study, even though they only showed Americans living in California. But they went back from 1973 to 2012 and looked at the incidence of tongue cancer. And they found every single year from 1973 to 2012, tongue cancer in white women under the age of 40, so from age 18 to 40, went up 0.6% every single year. And we have no clue why. It's not associated with smoking and drinking. Even if they do smoke and drink at that age, the exposure hasn't been long enough. It's not driven by HPV. And the reason I'm telling you this is because I want to remind you to screen everyone for oral cancer. So patients who develop oral cancer usually are older white men. They've been aware of an alteration in mucosa for 6 months, and it's painless, so they don't go seek care. And by the time they do seek care, if the oral health care professional doesn't have a high degree of suspicion, that delays treatment. And there's almost always evidence of a premalignant lesion before squamous cell carcinoma develops. So in my mind, we have a great opportunity here, but we have not managed to lower rates of oral cancer in the past few decades. But we can catch these. So very clinical appearance. It's hard to explain what oral cancer looks like. It looks ugly. I mean, that's like the best way for me to say it. It's exophytic, mass forming. It might be endophytic or, ulcerated, invasive. It can be red, white, or both. The exophytic lesions have an irregular or maybe even papillary surface. These all feel hard on palpation. The endophytic lesions usually have a central ulcer and then a rolled border, because what happens is the tumor sort of moves out. Well, I'll show you when I have a nice picture. I'll show you. So most common locations. So we have lateral and ventral tongue, floor mouth, soft palate, and then I put gingiva on here because those gingiva carcinomas really make me worried. Um, every time I see a patient who has gingival carcinoma, that has been seeing a doctor, they've been seeing ENTs, and the ENT has been treating it with steroids or antibiotics. So these gingival carcinomas can masquerade as periodontal disease. They can look like bumps on the gum. They're painless. They are not associated with tobacco use, and females tend to get them. So if you have a patient that's diagnosed with a squamous cell carcinoma, usually it hasn't spread unless they have an HPV-driven cancer. And if we do find spread, we'll find it in the cervical lymph nodes, which will be large, firm, painless, and they might be fixed, meaning the tumor cells have broken through the capsule and sort of anchored onto the anatomy. So you can't really pick it up and roll it around with your fingers. So treatment plan is to see the lesion and refer to perio or oral surgery or whoever you want to for biopsy. So the clinical stage will guide the treatment. So the patient will get wide surgical excision and usually radiation therapy. Sometimes patients will get chemotherapy, but it doesn't improve survival. If patients have large intraoral tumors, they'll get a radical neck dissection. Even superficially invasive intraoral carcinomas nowadays, they will do a neck dissection. They might do a selective neck dissection or modified neck dissection, but everybody gets a neck dissection nowadays. But you get a radical neck dissection if the tumor is large or if it's spread more than 3 millimeters into the tissue. So now I just want to show you a bunch of pictures of oral cancer. Some are going to be obvious like this, but some are not so obvious. And I'm going to show you some sort of pitfalls. So this patient, to me, this looks like cancer. It's on the ventral tongue, it's ulcerated, it's exophytic. But this was mistaken for a fibroma for a while. And in fact, when the surgeon did the biopsy, he cut it off as though it was a fibroma. Which totally obliterated the margins. So you have to have a high degree of suspicion. This is an example of one of those endophytic ones. So what happens is the cancer cells are going into the tongue here, and they're moving laterally. So as they move laterally, they're pushing up this border. And so it creates this rolled border. Here is an endophytic, ulcerated, and then exophytic lesion of the floor mouth. These floor mouth cancers tend to occur toward the midline. Actually, this might be more lateral ventral tongue, but you just have to remember to look because this is quite small. Here's another endophytic one. Again, they tend to occur toward the midline. This one's going up onto the gingiva, so this is quite a large tumor. This is my patient with squamous cell carcinoma. So an indurated lesion. So if you put your finger here and your finger here and press together, you really won't be able to. It's not very pliable. So this is an odd looking one. So underneath the tongue, so it's endophytic here, but you can kind of see where it's ulcerated. This cancer had been present for 8 months duration. This is actually a physician. He's an internal medicine doctor. He worked, when I say next door, I mean literally in the same building, just one door away. And he could have popped his head in at any time for a curbside consult, but he just wasn't worried about it. It didn't hurt. But after it had been there for about 8 months, he decided he better make an appointment with me. And by this time, the lesion was starting to sort of come to the lateral tongue, floor of mouth, and start to fuse. Um, and the scary thing about that is a lot of patients go to physicians and say, I got this thing in my mouth, rather than go to their dentist, because, they just don't know. So one of my goals is to better educate, like, it's not this physician's fault. He has no training in this. But we have to know to refer weird things. So here's one that might be mistaken for a bump on the gum. I mean, for me, it's hard. To me, this looks like cancer until proven otherwise. But especially if you're a young clinician, a young dental hygienist, you might say, oh, that's a red bump on the gum. Let's clean around the teeth and see what happens. But this is a squamous cell carcinoma. Another squamous cell carcinoma that's a bit more white in nature. This one's just, this is pretty ugly. I don't think you'd mistake this for periodontal disease. This was an 80-year-old female, and she came in to the school because her denture wasn't fitting anymore. And that was literally her only complaint. This was totally painless. But as you can see, her denture was not fitting anymore. So that's why she sought care. And this was a very poorly differentiated squamous cell carcinoma. Here is a lesion of the floor of the mouth. And these are subtle changes. So that's what I mean by, like, if you see this, don't shine a light on it to tell you what to do. If you see this, you biopsy it. But if you don't see it and you're doing your screening exam and then you shine a light on this and it helps you discover it, I think that's a perfectly great way to use oral ID. So, because this is quite subtle, and this was a squamous cell carcinoma. This one's not as subtle, but you can see where, especially if it's around here, it might look more like gingivitis. This one might look like a bump on the gum. This one should not be mistaken as cancer. So this is just spread everywhere. This one, goes right up to the dental papilla. To me, this looks like cancer, but I completely understand why someone would say this is a pyogenic granuloma. Here is this lesion. Here's what it's doing to the bone. It's resorbing the bone, and it's caused a pathologic fracture. This is a patient of mine. So you can see her cancer goes from here all the way back here. And what happened was the initial biopsy read out as severe dysplasia. And this is clearly not severe dysplasia. This is clearly carcinoma. But it's hard to biopsy these properly. I will not do them. I will let Dr. Nguyen do these. But because you have crevicular epithelium surrounding these teeth, even if you get a huge chunk of tissue, it might appear like the tissue is maloriented under the microscope. So these are just really difficult. Gingival carcinomas give me heartburn. I mean, they're hard to get a good sample. They're hard for us to diagnose under the microscope. If patients are treated, say, at MD Anderson, it's especially hard for head and neck pathologists who don't have experience with this to understand that they're cancers. So, I mean, if you get this, if you have a patient that has this and it comes back as severe dysplasia, you need to rebiopsy it. Like, this is clearly a cancer. The biopsy is just a formality to get the cancer treatment going. And this, I point this one out just because this patient also had to have several biopsies before we could call it cancer, because this tumor is growing so rapidly, it's losing blood supply. So all of this is just necrotic debris. And that's all we were getting on our microscope slide. So that's all we could call it, was necrotic debris. We couldn't call it cancer. And then I have examples of cancers in unusual places. So this is on the buccal mucosa in someone who had great oral hygiene, did not smoke, did not drink, and did not have lichen planus. and just for what it didn't use betel quid, just developed this cancer. I put this one in, not because it's a particularly great picture. This is a squamous cell carcinoma. It's diving in right here and sort of pushing out. But I want to remind you that the ADA says to do a cancer screening on every patient, every exam. So have your patients take their dentures out. If you're cleaning their bottom teeth and they have a top denture, have them take that top denture out. This one absolutely should be confused with a bump on the gum. This is a 17-year-old female with just this mass on the gingiva, and 20 times out of 20, I would call this a bump on the gum. I would not call this squamous cell carcinoma in a 17-year-old. But sure enough, that's what it was. It's just a plug to remember to turn your tissue in too, because you just never know. This one is a squamous cell carcinoma that it looks like herpes. So it's on the gingiva. Again, I'm telling you, these gingival carcinomas give me heartburn. So this had been present for longer than 2 weeks. So that's how you know when it's time to biopsy, this is no longer an infection. But to me, this is very easily overlooked, and a very astute clinician caught that and sent it to Dr. Viggy. Dr. Viggy is at UT School of Dentistry at Houston. This was a patient of Dr. Boco's. If any of you know Dr. Boco, he used to teach at UT Houston. This was a patient in the dental clinics, and this ulcer was present during their first visit. And it could be a recurrent aphthous ulcer, right? You know, recurrent aphthous ulcers are small, they appear on the tongue. But the problem is this student kept with this patient over the next 18 months, and this ulcer never changed, it never went away. If you look around, there's more ulcerations, there's more redness. And this patient had a squamous cell carcinoma that was uncaught by the student or the attendings for 18 months because it's so subtle. So you just have to remember to look, and any non-healing ulceration should be considered, any non-healing ulceration needs a biopsy, frankly. I just want to show this beautiful crown and bridge work that was done over the squamous cell carcinoma. Don't do that. And here's an example of a denture epulus, except for, no, it wasn't. It was a squamous cell carcinoma. So they kept adjusting the denture because this does look like an epulus. So they were adjusting the denture and this never went away. So after about a year, they biopsied it and it was squamous cell carcinoma. Another example of a very scary squamous cell carcinoma, easily overlooked. And this is probably the scariest picture that I have. I mean, who knows if I would even catch this? So this is a squamous cell carcinoma right here. I guess this is part of the larger lesion, but just remember to do your oral cancer screenings. So that's the end of my presentation. I wanted to save plenty of time for questions, but if you have any like pictures you want to send me, or you know, if your doctor does biopsies and they need a new pathologist, I take those. We have actually tons of contributors from Houston. I know those are really bad, especially this 17-year-old. I mean, my gosh, how does a 17-year-old get squamous cell carcinoma of the gingiva? And then this patient, it's ulcerated, so it sat there for a year while they were adjusting the denture, and they wrote about it. They published it. So does anyone have any questions over lesions that aren't red that you want to ask about? Like maybe you saw a lesion this week.
You did such a good job. There are no questions.
That's the only possible takeaway here.
Yeah,
it's sure. Not that this is an evening course and people have stuff to do.
Everyone's eating dinner right now while watching. Well, if there are no questions, you know, we like to thank Dr. Clark for spending the time, you know, in her closet away from her kids, lecturing to our hygiene study club. You know, I would say one thing I would say is that, you know, we're, you know, hygienists as well as doctors are very key in detecting some of these things. You know, the hygienist probably see the patients more than the doctor sometimes.
Almost, I would say more than 50%. So when I was working in Houston, more than 50% of my clinical oral pathology practice, a hygienist caught it and referred it to me. So the hygienists in general are very good about doing these oral cancer exams. You know, I'm not trying to shade any dentists. You know, they're looking at the teeth. And the hygienists are looking at the soft tissues, and they do a great job at catching this stuff. So thanks everyone for coming and listening to my children scream. I apologize.
You got a question, so.
Yes. So I have a private question too.
Okay. All right.
To whom should we refer? That's a great question. So most general dentists don't do their own biopsies. I encourage them to do so. It's a nice skill. It's a nice thing to be offered to your patients. And if I can do it, anybody can do it, quite frankly, because I have terrible hands. But there are a lot of lesions I'm not comfortable with. So I always recommend a surgeon, a dental surgeon. So periodontist, oral surgeon. The reason I recommend perio and oral surgery over ear, nose, and throat is because perio and oral surgery tend to give to oral pathologists to read the tissue, and we just have so much more experience. I mean, you wouldn't send me kidney to read, right? So I just want to make sure an oral pathologist reads the tissue. Another thing that people worry about is insurance considerations. So some oral surgeons do take medical, but if you don't have one in your area, then ENT might be more reasonable there. If you think you have a squamous cell carcinoma, that's a good time. But you guys are all in Houston, so this is a little bit different. So if you're in a rural area, that's a great time to refer to ENT, because the ENT is going to end up doing that surgery. So you want them to see it from the get-go. You want their pathologist to sign it out, because their pathologist is going to have to sign it out anyway. The person to whom I referred in Houston when I thought it was a squamous cell carcinoma was Dr. Melville or Dr. Yo's at Kentucky, Dr. Shum. So Dr. Shum and Dr. Melville take medical insurance, and they do, Dr. Shum does the cancer surgeries. I think Melville does too. So, and the oral pathologist, we get to sign it out, and we don't have to waste time sending it to anyone else. So it's a great resource if you have, not all oral surgeons will perform the final oral cancer surgery. But since you're lucky enough to be in a place like Houston, you have Dr. Shum and Dr. Melville there. Just to plug them, I guess. I have a candida question. Yes.
What's the question, Kara?
Oh, I have a separate question. And it's also about candida, and it's, let's say you have a female with candida, is it contagious? So should you be treating their children? Should you be treating their spouse? And the answer is no. So I've had uncomfortable conversations with men who have asked me if they got their candidal infection from their wife through the various activities that they might be performing. And the answer is no. That's not how you get a candidal infection in the oral cavity. So you're all good there. So just the person who has it needs to be treated.
Was that Kara's question? Kara DeLatin's question? Or is that a separate candida question?
That was Kara's question.
Okay. All right.
And hold on, I think I have one more.
Oh, you got one more. All right, good.
Okay. No, it's just someone saying they do screen with oral AD.
Okay.
So that's good.
Yeah. And we do in our office as well.
Yeah. So I think it's a great screening tool. I don't think it should be used to make decisions. Like if you see a lesion and it's red or white, biopsy it. But if you're using it for screening, that's great. If you have any other questions, feel free to email me. You know, I am happy to help. I have a very special place in my heart for this study club in particular. So if you ever need anything from me, I'm here.
We appreciate it. If there's no more questions, I want to reiterate some of the announcements from the beginning. We got like 30 more people come in. So one thing is Dr. Hale and myself are extending the membership that y'all paid for this year to the end of 2021. So whether we're in person or we're in webinar mode, it's going to be you kind of paid in advance. So there's no cost for next year. We'll figure out 2022 when we get there. And I will send the verification. I'll send the verification certificates as well as recording links in the next few days. And I'm going to shamelessly plug one more time. If you want to follow me on Instagram, I will post some oral pathology cases, some perio cases, some surgery cases. If you do like to see bloody pictures or sometimes not bloody pictures, follow me. I'll put it on the chat here. I think you got one more question before we get out of here. Let's see, Dr. Clark, you still there?
Yes.
Okay, you said, is there a lip product to use when patients are licking their lips in the middle of treatment of angular cheilitis?
Oh, that's tough. So there's not really. So basically the best thing to do is patient education. Like, you gotta stop licking your lips because you're reinfecting yourself. It won't go away. Usually if they're licking their lips, it's because their lips are chapped and dry and they're doing it on reflex. So what I tell them, and I don't know if this is like what a pharmacist would say, so let me just put a disclaimer out. What I tell them is to put the clotrimazole everywhere and then put some Vaseline on it afterwards, or Aquaphor, or whatever they want. Now I have them buy a new tube, so yeah, exactly. Someone said, yeah, you tried telling people to stop licking their lips. So you put the angular or the clotrimazole on first, and then a brand new tube of chapstick or whatever can go on second, as long as that clotrimazole goes on first. And then if they still can't stop, I'll just treat them with fluconazole. And if there's a bacterial component, maybe a triple antibiotic or something. But the clotrimazole is really effective in treating this angular cheilitis. I had mine for 5 years and it was gone within 2 weeks. And I threw away every picture I had of myself during that time. And I'm so mad at myself because I would love to show what it looks like.
Okay, I think that's it. We thank you, Dr. Clark, for talking to our hygienist, and maybe we can do this an annual thing.
Yeah, I would love to anytime.
All right. Well, thank you all.
Thanks.
We'll hopefully like to see you all in person at some point.
I'll be at Star of the South if it's in person, so keep your fingers crossed.
There you go.
All right, see ya.